So Dr. Farada, it usually takes an extra 5 minutes to fill up my screen. We're doing really well today. So I will leave it up to you as to when you and Dr. Sharma want to start.
Yeah, there's a lot of people already on the call. Maybe we can wait like 1 more minute and then we can start.
Sounds good.
1 minute, 10:31.
Yeah.
Okay, 10:31. I'm very, very happy to have you here today, Aman. So I have the pleasure to introduce Dr. Aman Sharma today. Dr. Sharma earned his medical degree at the Government Medical in Amritsar, India, where he also completed his internal medicine residency. He then became a professor at the Postgraduate Institute of Medical Education and Research in Chandigarh, which is the leading tertiary care hospital in northern India, also very well known for his educational medical research and training facilities. Dr. Sharma had received multiple awards from the ACR and ULAR. He is the current selected editor-in-chief of the Indian Journal of Rheumatology. His research interests include exploring different clinical aspects in the field of rare rheumatologic diseases, including relapsing polychondritis and systemic vasculitis. And his group had conducted various investigations that concentrated on the description of clinical presentation and outcomes, including, for example, the role of PET scan in assessing relapsing polychondritis, as well as science and proteomic studies in ANCA-associated vasculitis. Dr. Sharma is also part of the International Relapsing Polychondritis Research Network, and he has participated in different projects, including the Relapsing Polychondritis Disease Activity Index and the Relapsing Polychondritis Damage Index. He also has been the expert reviewer for the draft classification criteria for various vasculitis disorders developed from the ACR ULAR, sponsored by the DIVA study, and he also has established the Indian Vasculitis Registry and the Indian Relapsing Polychondritis Registry. So with all of those accomplishments and all of your experience, I'm delighted to have you here today, and I'm looking forward to your presentation. Thank you for joining us.
Thank you, Marce, for this very kind invitation. With this, I'll wish to share my screen. Is my screen visible?
Yes, sir. Yes.
And am I audible? So I'll start my presentation. Thanks for the kind invitation again from Marce and the NIH group. In my presentation, I'm going to share my experience of care and clinical research in vasculitis and relapsing polychondritis at PGI Chandigarh. I bring greetings to you from Chandigarh. Chandigarh is a capital of states of Punjab and Haryana. It's in the northern part of India. It is a city which was designed by Le Corbusier, the French architect. It's known as City Beautiful. We've got a beautiful lake and a rock garden, and as I said, it's at the foothills of Himalayas. This is the institute that I work at, Postgraduate Institute of Medical Education and Research. This has been declared as one of the institutes of national importance by an act of Indian Parliament. So if you look at the evolution of various classification criteria, evolution of the history of vasculitis nomenclature, a lot of pioneering work has been done even in the, by various gentlemen listed on the top of this schema, including Sean Lyon and Enoch, in the early part of the 19th century. And then we know the description of polyarteritis nodosa by Kusumal and Meyer. And then there was a first serious effort at having the pathological classification by Paula Zeek. Then as far as the biomarker discovery is concerned, these are the various timelines, but the most important was the description of ANCA in the late 80s and recognition of its importance in the early 90s. Then we of course know about the two Chapel Hill nomenclature system. The first one, which was responsible for the identification of a new entity called microscopic polyangiitis. Of course, this criteria was revised in 2012, and wherein the ANCA was truly incorporated assay was incorporated into the nomenclature system. And of course, we know that recently we've had the DC-VAS-driven ACR-ULAR classification criteria. So the diagnostic criteria, the classification criteria, and nomenclature has been something which has been really interesting for rheumatologists. And we really, all of us have moved away from purely a diagnostic criteria. And I think the ACR has also decided that there are no more going to be any efforts to have any diagnostic criteria, and we are going to have only classification criteria or a nomenclature system. So these are broadly the ones which are have got more importance. And besides the one that I've already alluded to, Richard Watt's group in Norwich, they proposed a criteria, an algorithmic system which was called the European Medical Agency system, published in 2008. They incorporated Sorensen's soft pointers, which included the nasal crusting, nasal obstruction, predominantly sinus symptoms, which are suggestive of granulomatous polyarteritis, and microscopic hematuria and glomerulonephritis, which is more suggestive of microscopic polyarteritis. And it was hierarchical. One started with EGPA and then went down to GPA and then MPA and polyarteritis nodosa. We tried to see how these criteria they fare in our group of patients, and we validated Richard Watt's EMA algorithm in our cohort of patients, 79 patients from 2007-2011, and as you can see, this algorithm did really help us in trying to minimize the number of unclassifiable patients which were there previously, to be classified in one of the other subgroups. But one thing which was kind of missing in this criteria was that the ACR PAN criteria were not really taken into the consideration. So perhaps if those were included, this might have become better. Subsequently, a lot of efforts were made, and this was one of the massive efforts at the DC-VAS study, thousands of patients from multiple centers all across the globe, the ACR-ULAR classification criteria. We had the opportunity to both recruit patients for this DC-VAS study, and also to be, I have got the privilege to be one of the expert reviewers for these criteria. And these were, at least 3 of these were published earlier this year. And the large vessel vasculitis criteria are, I think, on the way. They are probably going to be published in the next couple of months. So what we did, when the first DAS criteria for GP were proposed in 2017, a score of more than 5, these were a data-driven exercise, score of more than 5 was supposed to be suggestive of GPA. And something which was there in the previous thing, in the first draft, was nasal polyps were given a score of -4, although we are all aware that we do see polyposis even in GPA, and even rather this can give a biopsy evidence of GPA sometimes. And the other thing which was surprising was that there was no score given to any renal involvement. And if somebody has had a score of more than 5, with any manifestation, that would classify as GPA. Whereas if somebody had a possible glomerulonephritis and didn't have a PR3 positivity, it was practically impossible to make a diagnosis of GPA as far as this criteria was concerned. So we validated this in a cohort of 187 patients of ANCA vasculitis that we had. And as you can see, there was a lot of overlapping when we applied the ACR-ULAR criteria and also the other ACR older criteria, EMA algorithm, and there was a lot of heterogeneity with respect to the EMA algorithm. And what we noticed was that there was a lot of weightage to PR3. There was also weightage to eye involvement and a granuloma. There was no importance given to renal involvement. This was presented at one of the ACR meetings. Subsequently, this criteria was revised and the DRAS classification criteria were proposed the very next year, wherein that polyposis was taken off and the possumin glomerulonephritis on biopsy was given a score of 1, which was not given any importance in the previous criteria. We again validated this in a cohort which had now increased in size and presented at one of the ACR meetings, and I think there was still a lot of overlap amongst these various criteria. The new criteria, which has been published now, has been valid, approved by both ACR and the EULAR. This has, further clarified on the cartilaginous involvement of ear, nose, and also including the hoarse voice or stridor and endobronchial involvement or a sudden nose deformity. So this has been better characterized. We have validated this in our cohort now, and this has been accepted for presentation at the Philadelphia meeting. I think I can't share the results here. These will be shared at during the poster presentation at the ACR in Philadelphia. The other criteria we know that we validated was the polyarteritis nodosa 7-item criteria. We're all aware about the ACR criteria. We know that the ACR criteria of polyarteritis nodosa were proposed when MPA was not an entity. They were there in 1990, and recently we had DADA 2, which was also not known at that time. So this 7-point criteria, the points of which are highlighted here, we validated in our cohort, and when we applied it, and in 37 polyarteritis nodosa patients, 36 out of the 37 could be classified as polyarteritis nodosa, and out of 37 matched ANCA vasculitis patients, 7 could be diagnosed as polyarteritis nodosa. So this is a validation in a real life cohort in our population, and the results I've shared with you. So whenever we as rheumatologists, we talk about whether we can compartmentalize the diseases, as my mentor used to say, or the diseases read the book and come, the answer is no. We looked at the manifestations wherein the patients presented with things where it would make you very difficult for you to classify in one or the other categories. Like this was a patient with granulomatosis polyangiitis with a tumor-like mass in the thigh. Here is a isolated granulomatous GI vasculitis. There is the GPA presenting with a prostatic inflammation, prostatic obstruction, advanced renal failure. Here there was a patient with the dominant GI involvement as a manifestation. And this patient was a polyarteritis nodosa with Budd-Chiari kind of presentation. So these were kind of things which the books, the diseases don't really read the books and come. So it was important to highlight these aspects also. So moving on from the various criteria to following one set of nomenclature system to share our experience in different vasculitic disorders, I'll take you from the Chapel Hill nomenclature system. Sharing first our experience in large vessel vasculitis. When we were training, we were told that giant cell arteritis doesn't exist or is not seen in India. This is a write-up from Son Singh Hare. He's at the University of Iowa, very, very, very celebrated ophthalmologist in University of Iowa, who happens to be from Punjab, and he's done a lot of work on optic nerve and giant cell arteritis, and he wrote a review. And this dictum was held. So to dispel that myth, we collected the entire published literature from India, along with 17 patients of ours, and published some years ago. The data was till, I think, 2012-13, published in 2015. We accumulated 72 patients. The eye involvement was, half of those were referrals from the ophthalmology clinic because of vision loss. The other thing which was different was that our patients were almost a decade younger than what was reported from the Western population, but it was seen. But with more increase in our awareness and with availability of imaging modalities like PET, we are more and more now recognizing these, although it is not very common. Say, for example, we have around 340 patients prospectively recruited with GPA in our cohort. I think we just have around 50-55 odd patients with giant cell arteritis. So it is uncommon, but it's not that it is not seen. Based upon the voices which were raised, The Moorfields group also got interested and saw whether giant cell arteritis does occur in Indian subcontinent descent or not. And they saw that the probability of seeing the ophthalmologist in the Indian patients were as was there with the other cohorts, but the temporal artery biopsy positivity rates were lower. So they concluded perhaps this is uncommon or rare in patients of Indian subcontinent descent in UK. The other concept which has really evolved in the recent times is large vessel giant cell arteritis or larger vessel giant cell arteritis with cranial involvement. So we are now, since we now look for these, we are recognizing patients, some of them having pure extracranial giant cell arteritis also, and the imaging modality which helps us is a PET CT scan. These are the various arterial territories that we have identified. This is an unpublished data, just to experience that it is not very common, but it's not that it doesn't occur in the Indian population. The next is the most common vasculitis in Indian scenario is Takayasu arteritis. A lot of work has been done from our institution, including description of Sharma and Jain's classification, Sharma and Jain's criteria some years ago. Then now my colleagues from Lucknow, Durga Misra, and my other colleagues and their colleagues from CMC Vellore, Dr. Danda and Ruchika, these people are working actively in Takayasu arteritis. We also see Takayasu arteritis in good numbers. This was a PET CT scan evaluation in Takayasu arteritis, and the sensitivity in detecting active disease as defined by the NIH criteria was reasonably sensitive and specific. And I think we've had very nice publication from Peter Grayson and the NIH group, including very recent publication in large vessel vasculitis. So this entity really helps the clinicians in making clinical diagnosis, and its role I will further highlight in disease like relapsing polychondritis later on during my presentation. But one thing I wish to highlight, that many times the diseases don't really read the books. Whenever there is a beaded appearance on the angiogram, we presume it is fibromuscular dysplasia. But we've had a young male who presented with upper limb claudication, arterial involvement, increased inflammatory markers, and there was a suggestion of Takayasu. But with this angiogram, our cardiology colleagues believe that this is fibromuscular dysplasia. Drugs were stopped, leading to relapse in this patient, high increase in inflammatory markers requiring immunosuppression again. So what I wish to say is that these are very interesting diseases. Sometimes they might present with angiographic, which we've seen in other disease conditions also, mimicking like fibromuscular dysplasia. As I alluded to, I've had the opportunity to work closely with my friend Durga Misra from SUPGI, who's done a lot of work in Takayasu, and he's done a lot of meta-analysis and systematic reviews. I had the opportunity to review and be a part of those publications. And I think somebody who's interested can look up. In the interest of time, I can't really go into the details, but these papers can be looked up if in case somebody wishes to get more details on different aspects. Marce was talking about Vexus, and I still remember the day when she shared a mail that tomorrow morning that NEJM is carrying a publication on Vexus syndrome. I think it was 28th of October of 2020. And we were given an option that if you suspect some patients, the samples can be sent to NIH. Within a month's time, we had we at that time had an elderly male admitted with us she had superficial thrombophlebitis, also cytopenias, as you can see. Workup for MDS had been done, didn't really yield positive reports. The patient had ANA positivity, hypocomplementemia, so steroid-responsive cytopenias, and eventually we sent the sample to Dr. David Beck at the NIH, and within a month's time, I think the diagnosis was established, and this was subsequently accepted as a publication, as a letter in the AADR. And I was sharing with Marce just recently, we've seen a patient of gout recently, who also has been found to have ubiquitin-1 gene mutation. So a gout with Vexus syndrome, and then we have a third patient who was referred to us from the sample, was referred from Hyderabad. So at least I'm aware of at least 3 patients. We are also looking for Vexus in patients with relapsing polychondritis, and when we have enough mass, we'll probably be sharing that also. Going on to medium vessel vasculitis, we were interested in looking at how Hep B versus non-Hep B. We were always told that perhaps there are differences. The French group data suggests that there are differences in Hep B associated pan versus non-Hep B associated pan, and there in our cohort actually there were no differences between Hep B and non-Hep B associated polyarteritis nodosa. The other thing which interested our radiologically, some of Manful Singhal is a radiologist who is devoting his time to only vasculitis imaging at our institution. He's done imaging for most of the vasculitic conditions with us in Kawasaki and in other vasculitic disorders. This was a CT angiogram study, CT angio study done in polyarteritis nodosa. And what he showed was that not only the arterial changes like microaneurysms, the narrowing, stenosis, etc., but the end organ changes like organ infarcts, splenic infarcts, the renal infarcts are important, and it is a good modality which can help you. It is in establishing the diagnosis of polyarteritis nodosa. We may not really need invasive DSA or angiogram. The other thing which excited us was this publication from the NIH group, and also the back-to-back publications from US and from the Israelis group on DADA2, Dr. Zhao, and led by I think the stalwarts in the group. New disease entity was DADA2 was described in 2014. We saw our first patient in 2017, and we accumulated our experience from PGI Chandigarh and then from all other colleagues from India. And in this work we were helped by my friend Puili in Harvard, Boston, and we collected patients, 33 patients. And what was different in our cohort was that, unlike the entire published literature till that time, where the median age was just 4 years, in our cohort, the median age was 15 years, with one of the patients being diagnosed well into the 40s. So it is just not merely a disease of childhood. Although we had pediatricians, we had the children also having DADA2, but we had a large number of patients in adulthood. Now we have around 50 odd patients of DADA2. And the other thing that we saw was it was seen particularly in a Jain Agarwal community of North India. So whenever those patients now come with strokes or other manifestations which are suggestive of medium vessel vasculitis, then it is important that people consider about it. And I think we are seeing more and more referrals. We now established some facility to diagnose do the genetic analysis of DADA2 at PGI. And I think the early days of DADA2 enzyme assays also at PGI Chandigarh. That facility is now being offered to all the patients from the country. So besides in the imaging, we know that there can be the ischemic strokes, there can be lacunar infarcts, there can be hemorrhagic strokes, or both in these patients. But we did see unusual manifestations like posterior reversible encephalopathy syndrome in one of our patients. In abdominal imaging, as I've already alluded to, besides the organ infarcts, mesenteric ischemia, the common infarcts were in splenic infarcts, renal infarcts, perinephric hematoma. We also saw pancreatic infarcts. The thing which was different from the NIH group, Dr. Umbrella's group had described focal nodular hyperplasia, cardiac infarcts. We looked for those, but we didn't find in any of our patients. None of our patients had focal nodular hyperplasia. We did see microaneurysms, and we also saw peripheral arterial narrowing in larger vessels, including ulnar artery inclusion also in these patients. This is the pancreatic microaneurysm and pancreatic infarct in these patients. This is a dramatic angiogram. You can see these microaneurysms studied all over in the abdominal vessels, but also in the intercostal vessels. So you can see the microaneurysms even in the intercostal vessels. In the histopathology, not only vasculitis was demonstrated, but significant number of patients also had vasculopathy. So what I wish to say is that if there is vasculopathy on biopsy, that doesn't really exclude DADA2. The Umbrella's group had shown that strokes don't really recur once anti-TNFs are started. And what we showed that once you start therapy, not only the CNS manifestations improve, but the other manifestations of DADA2 also improve if they are started on anti-TNF therapy. But the challenge is one, we also saw novel mutations in somebody which mimicked antiphospholipid syndrome. When the patient developed ulceration, started on anti-TNFs, and the patient hasn't had recurrence of any symptoms ever since. Puili's group also, we were associated in some way, but the work was done at Harvard, led by Puili at Harvard Boston. We estimated the carrier frequency of 1 in 236, with probably the prevalence is 1 in almost 200,000 patients of data too. Now coming on to small vessel vasculitis, something which is the most common is granulomatosis with polyangiitis in India. Previously, whenever people used to talk about ANCA vasculitis or GPA especially, it was said that just like Japanese have more of MPO positive GPA, which is seen in China also, perhaps the Asians have MPO positive GPA, which was actually not true. What we had was PR3 positive GPA, actually just like our Northern European colleagues. It was not MPO positive GPA, but it was PR3 positive disease, and the phenotype was also similar. So this was our experience of 105 patients. So we are more like the GPA which is in Europe and not like what is reported from Japan or China. The other thing which was different when we compared it with Alfred Mahr's group or Julia Holle's group or Reinhold Keller's group in Germany, Dr. John Stone or Gary Hoffman, was that the renal involvement is less as compared to described from the other cohorts. Renal involvement was less even in a cohort from Delhi. So, and which made us write this review, which said that it is not really different. People presume that in Asia it is different from what is reported from the West. So the other thing which intrigued was we encountered pregnant patients who came with active disease well into the advanced pregnancy. So that made us look for do a systematic literature review of pregnancies, and there were 32 pregnancies which occurred. 32 patients had disease occurring during pregnancy, some before and some afterwards. Fetal outcomes, 66% had term, but 20% had preterm, and 10% had abortions, and 3 had stillbirths. And if you look at the repertoire of drugs which have been used, these are all listed here. So the people had used cyclophosphamide also. If you draw analogy from what the gynecologists do, there is a life-threatening condition, and they say that we are probably going to focus more on the maternal outcome and disregard the baby in an effort to save lives. So, and even with these drugs, successful pregnancy outcomes have been reported. We used rituximab in 2 patients at that time with successful fetal pregnancy outcomes and no B-cell depletion in children. We have now used drugs in, I think, 4 pregnant patients with active disease with good outcomes. So I think that is what gives you some confidence in going ahead and treating these patients during pregnancy. The other disease which always intrigues us, tuberculosis, is endemic and very common in India. So the question, if there is no renal involvement, the question which is always asked is there a way by which we can radiologically differentiate GPA from tuberculosis? We tried to compare the imaging that we had in GPA patients and divided the changes according to nodules, consolidation, GGOs, cavities, and other aspects on the next slide. So basically what we saw was that inner wall margins are irregular in the cavities in tuberculosis and mostly smooth in GPA. Air fluid levels are far more common in TB and are much less, although they can be seen in GPA, are much less. Something which was very important, and it helps us clinically here in India, is that hilar adenopathy or mediastinal adenopathy seen in TB was not really observed in any of our GPA patients. And effusions, if at all, they are very minimal. So if there is minimal effusion, sometimes the minimal effusions are there because of the renal involvement. If there is hypoalbuminemia, those patients might have some effusion. But gross effusions and hilar adenopathy is something which should make you think about tuberculosis more than GPA. So the other question then we wanted to answer was whether there can be ANCA positive in TB. So we took only TB patients, which were microbiologically proven TB patients, and did ANCA assays and ANA assays in them. And one thing which I wish to highlight is that you'll be surprised that up to around 8% of patients had PR3 positivity. and some of them very high titer PR3 positivity also. So basically, we have to be very careful in interpreting PR3 positivity with some pulmonary shadows, and I think we have to look for other things and see the patient in totality and just not be driven away by some shadow and a PR3 positivity in a tuberculosis endemic country. The other challenge that we always encountered is the Indian patients have to bear cost of treatment. Most of them, they have to do out-of-pocket expenses. The insurance covers are not very high. So when rituximab came into being, the questions were asked whether you want to use a biosimilar drug in a life-threatening condition, or you would use the innovator, because people thought that perhaps since the data is from the innovator drug, would you be confident? But in India, many times the decisions are driven by the cost considerations, and we looked at our own data of use of biosimilar rituximab in patients with GPA, and then looked at the inductions and the maintenance data and compared it with the available data from, say, in the induction group, the rave rituximab and the French vasculitis group data, and I think our patients did almost as well in the induction phase, and similarly in the maintenance phase also we had reasonable follow-up and the reasonable number of relapse percentages and reasonably good mortality outcomes in our patients. So I think we can say that with this data, all of our colleagues in India and around the world can perhaps use biosimilar drugs with great confidence in this disease condition. All the entire world has been affected by COVID, and when the COVID came, we were not really very sure what we are going to do in ANCA vasculitis patients. So we thought that perhaps let's do an online survey. This was the early part of the COVID epidemic. We did an online survey, and I think we had more than 300 responses from entire world. The remission induction people chose rituximab or cyclophosphamide in majority of patients. We had given a case vignette of a patient with GPA with active disease. The reasons of choices were efficacy, fertility, preservation, less infections vis-a-vis other things, and remission maintenance also. Rituximab was the chosen drug by majority of the people who responded. In treatment of a minor relapse, people thought that perhaps you might get away by just hiking up the steroids, whereas if there was a major relapse, there has to be a change in the immunosuppressive therapy. And these are the patients, if they develop COVID, what they will do. So then we gathered our own experience of managing COVID in patients with GPA. 33 of our 180 patients had developed COVID. And in the demographics, barring the fact that none of our MTA patients developed COVID, the rest of the other demographics, we compared a group which developed COVID vis-a-vis which did not. And these are the different drug regimes which had been used during the COVID times. I can tell you 1/3 of the patient had mild disease, 1/3 had moderate disease, and almost one third had severe to critical disease. And 9 patients, they developed active vasculitis at the time of COVID-19 illness, and 2 of them with a critical disease, they succumbed to illness. There was 1 more mortality. A patient died at home. We could not really ascertain the cause, whether it was because of active disease or because of COVID or because of a sudden thromboembolic or a cardiac event, actually. So the thing is that we looked at the predictors of severity of COVID in our cohort, and the use of rituximab or any other drugs didn't really have any statistical significance. Only thing which stood out was hypothyroidism, which has also been shown to be associated with severe COVID in some of the studies, and ocular involvement due to AAV. So the other drug use, importantly, was not. So if somebody comes with the active disease, perhaps, although the numbers are smaller, but I think this would give you some confidence of use of drugs in ANCA vasculitis patients. I alluded to that, we in our cohort, we had a milder renal involvement. We looked at the impact of renal involvement in survival, and in a very small number of patients had ESRD as compared to reported from the Western literature. Although these had a more relapsing disease, the mortality, they had not only the renal cause of mortality, but there were other causes contributing to mortality also. So independently, it was not really contributing to mortality as compared to the other manifestations of ANCA vasculitis. In our cohort, my colleague Shankar Naidu, who is faculty colleague, his residency thesis was Burden's classification system in Burden's classification in ANCA vasculitis in our cohort, and as was known from the Burden classification system, the patients with focal disease had the best outcome, followed by the ones with crescentic disease, mixed disease, and the ones with sclerotic disease in PIGN had the worst outcome. We also looked at whether ANCA positivity can help us in looking at the outcomes. We looked at the patient with possible glomerulonephritis, those who were ANCA positive, vis-a-vis ANCA negative. Those ANCA negative patients, the ones who had ANCA positivity could be classified as MPO, and those who had renal involvement with PIGN, but ANCA negativity, they were here as unclassifiable according to the criteria. And the ones who had ANCA negativity, they had poorer outcome. There was more deterioration, more dialysis dependence as compared to the ones who were ANCA positive. We looked at neurological manifestations in our patients, and they are comparable to what has been reported from most of the cohorts. This is a busy slide, but there is nothing different strikingly from other reports. Only thing was that, again, like renal, independently they didn't really affect survival. One thing which I wish to drive home is that many times you've seen ANCA vasculitis presenting like giant cell arteritis actually. So if we have a temporal artery-like presentation, we are more keen to see whether this is presentation of AAV or it is because of truly giant cell arteritis. What is different from GCA is that in our cohort, we saw that there is a reversibility of vision loss, which was seen. Now we have, I think, around 4 patients. This was a report of 2 patients in response to the French group data, which was published 50 patients. So we wanted to know whether there is a reversibility in their cohort also, which we saw in our patients of TAAV. Our PhD students and residents, rheumatology fellows have worked on cytokine. This was the work of a PhD student in immunopathology, cytokine profiles and proteomics work done from our institution, and HLA and non-HLA association in ANCA-associated vasculitis. And one of our DM students looked at the increased gene expression of B-cell activating BAF in remitting patients with ANCA-associated vasculitis. Because of paucity of time, I don't have, I am not discussing these. As far as immune complex vasculitis is concerned, HSP many years ago we saw with severe mesenteric ischemia requiring steroids and cyclophosphamide. So contrary to what we believe that this doesn't really require aggressive treatment. Behçet's disease, again, we have had published experience of ocular Behçet's. We recently published arterial involvement. We have seen aortic aneurysms. We've seen pulmonary artery aneurysms. We've seen peripheral artery aneurysms, femoral artery aneurysms, dorsalis pedis artery aneurysms, some of which remit on immunosuppressive therapy. We've had done surgeries and percutaneous interventions also in these patients. We now have a cohort of more than 150 patients of Behçet's disease. Single organ vasculitis, we've seen giant cell, large, isolated granulomatous angiitis of GI tract. We do see CTD-associated vasculitis. RA vasculitis is decreasing in numbers. We still do see lupus vasculitis. We've seen a couple of patients of NSG and sarcoid vasculitis. We've seen a patient, 3 patients of ANCA-associated vasculitis with renal failure in patient with systemic sclerosis. And of course, I'm going to talk about RP. This was a patient who presented with vision loss, optic nerve head involvement because of sarcoidosis. This is a patient which made me interested in relapsing polychondritis. When I saw these ears and nose involvement, I went to my mentor. Could this be relapsing polychondritis? I think this was the first patient that I saw in 2005. That's immediately, and this was a nose involvement in this patient. We learned to see for the ear involvement, as is highlighted here, and more so here, and more mutilation here and here. And then I collected 5 of my patients, and 5 patients were given to me by my mentor, the Bambri. And by 2007, we published our experience of 10 patients. And I was already getting interested into this disease. And by 2014, we had collected 24 patients. Some of them but at that time, perhaps we were doing CT angiograms whenever we were indicated. We were thinking that perhaps airway involvement is less in our patients. But one thing which changed my approach to these patients was this young lady who had CT done, protocol CT normal, trachea bronchi normal, still 5 days later developed a stridor requiring tracheostomy. We gave IV methylprednisolone but continued to worsen and had to be given cyclophosphamide. So I think I'll have to go back to the. So basically, this was a patient who developed left main bronchus occlusion despite that. And I think even the bronchoscope could not be negotiated. You can see the left main bronchus here, which really improved post-therapy. And this is the pre-therapy, this is the post-therapy. So this we thought that we have to recalibrate our response. Then that is when we started doing PET in these patients. And I can tell you that PET does help in initial choice of therapy. Say, for example, if the patient just has auricular chondritis, but shows up a signal, intense signal on aortic root or in the airways, the quantum of response therapeutic response is going to be set down or not. Say, for example, if there is an airway involvement like this, or if there is an eustachian tube involvement like this here, or if there is aortic involvement. This was one of our residents who had initially had features of Sjogren's, then developed relapsing polychondritis features. And when we did the PET, there was thickening and there was increase in the signals. We had to, choose higher generation immunosuppression, arytenoid cartilages, aortic root, ascending aorta, right and left main bronchi. So this was another interesting patient in South India. Discussed with me, the patient was on ventilator with airway involvement and not responding to anti-TNFs when steroids and cyclophosphamide were introduced. The patient did get better. There were some symptoms. The patient came to me. That is when we did this Phylon therapy. And after looking at this PET, we thought perhaps we were initially thinking of stepping down the therapy a great deal, but it perhaps the imaging suggested that it is still not time. And then we had to do it later on. So it helps us in treatment response. Based upon this, we published our experience in Rheumatology, Oxford. And subsequently, thanks to Marseille and Peter and their colleagues, we were invited to be a part of this work, which was published from the NIH, wherein the physician's global assessment was, the role of physician's global assessment was assessed in relapsing polychondritis. And as you can see, there were 3 evaluators from the NIH and 3 evaluators from abroad. One was from, beside myself, Laurent Arnoux from France and Hajime from Japan. And you can see, although there was a concordance between the yellow, between the black rounded circles, which were the NIH evaluators, the reviewers thought perhaps they are teacher and the same taught. And the reviewers were right in the sense that there was a discordance between the physician's assessment in a given set of clinical details was there between the NIH group and those from abroad. So this helps us in having better tools which can be, which has less inter-observer variability. I was lucky to be a part of this relapsing polychondritis disease activity development tool led by, again, Laurent Arnoux, and also disease activity damage score, which has been developed. And I think now Marcella Frada is at the forefront. We contributed to this international consensus exercise to develop items for classification criteria of relapsing polychondritis. And I think the efforts are still on to move forward and to have more collaborating research. We've had such exciting data coming from the NIH regarding RP with Vexus. And I think she's been pretty busy in the last couple of years with a lot of quality work being done, which is making impact all around the globe. I think with this, I would wish to conclude, and I think I'm right at around 43, 44 minutes of my allotted 45 minutes. I wish to conclude that my focus has largely been on patient care and clinical research. Rheumatology is an exciting specialty, and I think within the institution, within the country, and within all over the globe. Collaborations are the key to find out answers to questions to rare diseases which impact lives all across the globe. I think I would wish to acknowledge my mentor, Pradeep Bambri, my colleagues from within the department, various other specialties, histopathology, immunopathology, nuclear medicine, nephrology, my own departmental colleagues, radiology, other colleagues from gastroenterology, microbiology, my interinstitutional colleagues from SGPGI, bunch of our residents, my international colleagues here, and some investigators from NIH who worked in some of our work that I've shared. Thank you very much for your patient hearing, and I'll be very happy to answer any questions.
Hi, thank you so much for your presentation. That was very, very good. And thank you so much for sharing all of these interesting cases. I mean, vasculitis it is an interesting word. And of course, I have my particular interest in relapsing polychondritis, which I still am vexed at now. But thank you so much for your presentation and spending this morning with us. And let me see if there's any questions here.
Dr. Marquez has a question.
I don't see any. Who has a question? If whoever has a question. Oh, hi. Go ahead, Marianne.
Hi, Dr. Sharma. This was an amazing presentation. Thank you so much for sharing your knowledge. I do have one question. I was really interested about your data about the patients because you had a relatively late age of onset. So I was just wondering, is there a role just sending genetic testing for every patient with that, like who presents with the polyarthritis and those phenotype, even if they don't have CNS involvement? But like, I was just thinking about a patient that I saw that was a little old, but the most difficult to use PA again. And he had been responding well to his thyroid, but like, he never had any CNS involvement.
I'm sorry, but I'm not really able to hear you clearly. I mean, can you asking about data 2 and sharing a patient of data 2 with?
So might I suggest that Mariana, because of the feedback, it was very difficult to hear. If you could post your question in the chat, and then we can go to Dr. Lanata and then come back to your question, if that would work. Thanks.
Yes, hi, thank you for that wonderful presentation. I'm sorry really if I missed this, but I don't see data coming from India very frequently. And I was wondering if you could comment on just the general prevalence of vasculitis in that area compared to what we see here or in other places. I know it's a tricky question.
No. I think that's a very valid question, very important question. So the issue is the most common vasculitis in India is Takayasu arthritis. So it's more, I think we see all over. We see North India, South India. There is no regional divide. We see all across. There are larger cohorts in down south, but in Lucknow, but we number of Takayasu. So that's the commonest. We see a lot of ANCA vasculitis also. Perhaps to me, in northern India, ANCA vasculitis is more common than Takayasu. Whereas our South Indian colleagues don't really see that much Takayasu, and people have talked about genetic associations and whether there is a difference in the genetic pool in North India as compared to Southern India. So amongst the ANCA vasculitis also, we see more of GPA, granulomatosis, polyangiitis of Wegener's granulomatosis, and it is PR3 positive GPA. Then the next is microscopic polyangiitis, and Churg-Strauss is rarer. I think that's in sync with what is largely the prevalence of ANCA vasculitis in most part of the world. Polyarthritis nodosa, it is relatively rarer, but as you can say, India is we have a 1.3 billion, 1.4 billion population. So we have collected 33 patients in no time, and we are already touching 50 as far as data 2 is concerned. So it's not that rare. Having said that, we see our pediatric colleagues from our institution has one of very large cohorts of Kawasaki disease. We have a special unit of rheumatology, pediatric rheumatology. They see a lot of Kawasaki. A lot of published work has come from Kawasaki. And there is some other data from PGI also. My mentor had worked on Wegener's granulomatosis, as it was known, in late 80s and early 90s. So that time also there was some published experience of Wegener's from India. So giant cell arteritis is relatively rare, but it is not that it doesn't occur. And I think if I could say, perhaps we see both. Say maybe if I see 40 to 50 patients of GPA or perhaps ANCA vasculitis in 1 year, I would be seeing maybe 5 patients of giant cell arteritis, both cranial and extracranial. So if that gives you a rough estimate, but if I could tell you, our institute has a large draining area, and the number of patients which are referred to our institute are around 3 million patients are seen in the institute every year. It's the entire institute, not our department alone. So it's large feeding area. So whatever numbers I'm telling you has to be seen with that denominator. I hope I've answered your question to your satisfaction.
Yes, thank you so much. That's very interesting. Thank you.
Okay, we have the question here from Mariana.
Yeah.
So she's saying,
Yeah.
I was impressed about the older age of onset of your data to cohort. So I was wondering if there is a role of sending genetic testing for every patient presenting with a PAN phenotype, even if they don't have CNS involvement. My question was prompted by a patient of mine who had cutaneous polyarteritis nodosa and has been well controlled on azathioprine, but if we were to have data too, could he still be at risk for strokes?
Actually, that's a very, very important question. Thank you for asking that question. That's a very important and a very relevant question. The thing is that if the facilities are available, I think it should be done in all. But if you have to choose, then perhaps somebody with a extensive livedoid racemosa kind of rash, which is not only confined to the lower limbs, but confined on the trunk and the upper limbs also. And of course, if the patient is not responding to conventional drugs like azathioprine, cyclosporine, in the interest of time, and then I had that slide, they generally don't respond to azathioprine, they don't respond to methotrexate, they also don't respond to cyclophosphamide. So what we generally do is, if there is a relapse, you'll go up on steroids. Steroids do work. So, but if the patient is not having other features, responding to azathioprine, the probability of it being DADA2 is relatively lesser. But if they don't respond to conventional immunosuppressive drugs, which include cytoxin also, then you have to seriously consider. If you look at the CNS manifestations, not only the neurological, the central nervous system manifestations, but subtle neuropathies are also known. You might have, some numbness and tingling and paresthesias. And when you do a nerve conduction, you'll get the evidence, and then you nerve biopsy, which will show vasculitis. So you will have to look for those soft pointers, which is not really bothering the patient too much, but just irritating. That is where you can pick up the cues. Or they have cardiac involvement, which is unexplained, and the patient is not responding. The PAN patients, which we pick up, wherein you have a fever, you have unexplained congestive cardiac failure, actually. And then you do a CT angiogram, you see the renal infarcts or the splenic infarcts. And of course, the inflammatory markers in most of them are positive. So I hope I've not confused the picture more than adding on to what you wanted to ask me. But if it is ideal and the resources are available, we do it largely for all. For enzyme levels, I think as of now, we have to send samples to Pui Lee in Boston. He's a charming person. He's a very, very helpful guy. And if you get in touch with him, he will send you the report within 3 days and won't charge anything.
Good to know. Thank you. Dr. Quinn?
Yes, thank you, Dr. Sharma, for a great presentation. You spoke a little bit about GPA and tuberculosis, but I was wondering how frequently you see aortitis secondary to tuberculosis, and how you go about differentiating from other forms of large vessel vasculitis, if there are specific features on imaging that you look for.
Actually, we haven't really seen TB with aortitis very commonly. We, at our institution, we do the autopsies in unfortunate patients who pass away. It's a medical autopsy to learn. And in the pathologies, I remember in 20 years, one of our chiefs of internal medicine, he discussed a case wherein there was abdominal lymphadenopathy, and around that abdominal lymphadenopathy there was aortic involvement. And in one patient, there was, in another autopsy, there was TB besides the active Takayasu. So I'm really, in my 20 years of experience, I'm really yet to see a true, without those nodes, only isolated aortic involvement because of tuberculosis. People have talked about HSP, heat shock protein and all that, and demonstrated that that is there in the biopsy specimens of Takayasu. But TB only presenting with aortitis, no other features of TBs would be probably odd. I haven't seen that. If somebody else has seen, perhaps can share. One thing which intrigues us is IgG4 disease, which we are all aware. I mean, that is something, sometimes it can be very, very difficult to tease out whether it truly is IgG4 or it is Takayasu. Occasionally, I mean, sometimes it is clear you have other areas involvement, you have, along with the cuffing of the vessels. But if it is purely aortic involvement, at times it might be difficult to differentiate between the two. I hope I have answered your question.
Yeah, thank you.
We have one more question here. The question is from Rahul Visarali, and is the role of autoantibody testing in relapsing polychondritis.
Well, people have looked at cartilage. Marce can answer this question better than me, but I think we don't do any autoantibody positivity in relapsing polychondritis for diagnosis. The people have looked at anti-cartilage antibodies of various types, and I think there's some literature from Japan. I have never done it, and I don't know whether Marce, I think she's the expert, she can tell if they have done it in clinical setting. Practical doesn't have any role. Sometimes antibody testing, if you have a confusion with GPA, it can really happen. You have a nasal bridge collapse, you have some hearing impairment, and you have some plus minus cartilage involvement. People say historically they had some tenderness. At that time, you are not sure whether it is collapses because of localized GPA or because of relapsing polychondritis. You do a PR3 positivity and see whether it's GPA or that's a very small subset of patients where you're not really very sure. Rather, with autoantibody, you're looking more for GPA than kind of trying to see for RP. I hope that's what my take would be on doing antibody testing. But rather, I will wish to hear from Marce if she has to say anything else.
Yeah, so we had, historically, the antibodies that have been used to diagnose relapsing polychondritis is anti-collagen 2 antibody. That is not what we have seen in our cohort. However, there is a particular subgroup of patients, which is patients that have MAGIC syndrome, where we have seen perhaps maybe a little bit more prevalence of the collagen 2 antibody. But collagen 2 antibody is not specific. It doesn't track with disease activity. So I think that we really need to get the data out so to let people know that it is not the test to diagnose patients with relapsing polychondritis. And actually, the original data from the collagen 2 antibody, it came from NIH in the 1970s from Dr. Katz. And that included 15 patients with relapsing polychondritis, and that is what everybody refers to. So we need to provide that information so that people have a better understanding that this is not a diagnostic tool for relapsing polychondritis at the moment. Yeah.
Thank you, Marce, for helping me.
No. And then I don't know if anybody has any other questions, but I don't see any other questions here. But this was it was a wonderful talk. Thank you for the overview on the cases and sharing all your experience. Dr. Criswell.
Oh no, I agree. Fascinating. What a wealth of experience you've collected, and so many research opportunities suggested by some of this data in terms of genetic contributions, environmental contributions, how we're thinking about disease. So really learned a lot and appreciated your presentation and the discussion.
Thank you very much for your nice compliments and for the invitation. I really enjoyed being here and such a lively interaction.
Yes, thank you, and thank you to everyone else who logged in for the presentation. It was really nice.
Yeah, thank you, everybody.
Thank you.
And
Thank you.
Trey.